Thank you very much. We are going to move into the world of TB. We have a lot to learn from the HIV models, and I'm going to give my talk in English.
Thank you very much for your introduction. I will present today our intervention about community household child contact investigation for tuberculosis. The WHO estimates that there are 1.3 million children with TB, and more than 200,000 of these children die. This represents 12% of the global TB burden, and also 16% of the global TB mortality. So you see there's a gap between these estimates. And highlighting this gap in diagnosis and treatment, we estimate that 58% of children under 5 years are underdiagnosed or underreported. Many of these children get tuberculosis in their households. Therefore, the WHO recommends TB preventive treatment in the households of these children. There are different regimens, and the one we are going to highlight today and focus on is 3 months of rifampicin and isoniazid. In 2022, there were less than 37% of household contacts who actually received TPT. And in the countries that we did this research in Cameroon and Uganda, so there have been 1.3 eligible contacts receiving TPT in Cameroon and 73% in Uganda. And these percentages were even lower when we developed the intervention. The current recommendation is for the person who has TB to bring their household contacts at the health facility for TB screening. And this is focused on children under 5. But there are many challenges, as we know. First of all, time, scheduling challenges, financial difficulties, the distance from the health center, and also stigma and disclosure issues that are still very present in the TB world. So we proposed a solution to send teams into the households to do community household TB screening for these children and TPT management. So the objective of this project is to compare the proportion of household contact children who start and complete TPT between a community-based model and the standard of care. So this is called the CONTACT study. CONTACT comes from Community Intervention for TB Active Contact Tracing and Preventive Therapy Management. This is a study funded by UNITAID through the CAP-TB project. It's been led by Institut de Recherche pour le Développement, and it's been implemented in Uganda through Epicenter and in Cameroon through EGPAF. The project had 3 phases. First of all, in the baseline phase, we looked at retrospective data from the registers, and we checked the quality of these data. And also, we asked the patients and caregivers if this intervention would be acceptable, and we adjusted it according to our findings. In the intervention phase, we recruited and followed out the participants. And in the explanatory phase, we analyzed the data, we did the cost-effectiveness analysis, and also the post-intervention acceptability. It's a multi-center randomized control trial with 20 clusters. These clusters are 10 clusters in each country. And in Uganda, the intervention took place in the southwest region, and in Cameroon, in Littoral et Région Centre. There are 2 parallel arms. One is the intervention, which is the household community-based intervention, and the other one is the standard of care, which is facility-based. For the inclusion criteria, we included index cases, so people diagnosed with TB in the previous month, who accept the household visit. And then when we went into the households, we had a secondary inclusion criteria for household contacts, and we included all ages. In the standard of care, all activities are facility-based. And these activities are TB diagnosis, TB contact screening, investigation for symptomatic contacts, also TPT initiation, follow-up, and completion. Everything happens at the facility, at the health facility. In the intervention arm, the index case is diagnosed in the health facility, but after this, we send a team in the household to screen all household members. So we screen for TB symptoms and also for critical signs in case any child has important critical signs and they need to be referred for a health assessment. And also we propose HIV testing to everyone. If there are symptoms, the household contacts are referred to the health facility for investigations that are available there. This visit is done by a community health worker. Then this community health worker identifies the contacts who would need TPT. There's a second visit by a nurse, because only a nurse can prescribe TPT. And we prescribe the TPT to children under 5, and also children 5 to 14 living with HIV. Also, the nurse makes sure that the child doesn't have any symptoms, so there's a secondary assessment, and also there's counseling for adherence. Then the follow-up in the intervention model happens at 1 week, 2 weeks, and then monthly until the end of therapy. At each follow-up visit, children are screened for TB symptoms, critical signs, and also tolerability to TPT. And also, adherence counseling is redone at each of these follow-up visits. If there is any symptom suggestive of TB during the follow-up visits, the children are referred to the health facility. So these are the results, and here I want to highlight our primary endpoint, which was initiation and completion of TPT. We looked at this population through different ways, different analysis. So we did per protocol analysis, intention to treat analysis, and all showed an effect, and they're all significant. And I just want to highlight the primary endpoint. On declared child contacts, we see that in the intervention group, we have 80% of children who start and complete TPT, and in the control group, we have 62%. And this translates to a 3-fold odds ratio of completing TPT through the intervention model. We also looked at the cascade of care, and we see very well, so we have here the intervention group in red and the control group in blue. So at the screening level, we see that we screen a lot more through the intervention group. Then among those who are considered eligible for TPT, there's not a significant difference between the two models. But then for completion, and after the follow-up period, we see that we have 93.5% of children who complete in the intervention model, and 76.7% in the control model, in the standard of care. We also performed an acceptability assessment through a qualitative study. So we asked patients, we asked caregivers, we asked health staff, community leaders, what they think of the intervention that was done. And they all consider it's acceptable. We also performed a cost-effectiveness analysis. So we see that in this intervention prevented 15 deaths related to TB in Cameroon and 10 in Uganda. And the ICER, so the incremental cost-effectiveness ratio, was $620 per averted DALI in Cameroon and $970 in Uganda. We also had ongoing discussions with national stakeholders who are convinced of the effectiveness of the intervention. So we see it works. It's something that people want. It's an intervention that is acceptable, it's cost-effective. Stakeholders are on board. There have been other interventions in the literature with similar findings, especially in Eswatini, with a 93% TPT completion under the community intervention, so it's very similar. And the open question now, that is not the scope of this project, is how to fund these activities on a long term. So I don't have the answer to this one. If you want more information about this project, we have several publications that are already out there. There are many details that I cannot convey in 10 minutes. So I will invite you to check this out. And I would like to thank all families affected by TB who participated in the study, the implementing teams in Epicenter and Barara, the implementing team in Cameroon, in EGPAF, coordinating team in Geneva, and the coordinating team in the IRD, led by the PI of the study, Marilyn Bonnet, who is also the best PhD supervisor that one could have. And thank you for your attention.